Hello, and thank you for joining today's webinar, When Innovation Meets Hesitancy, Building Public Trust in mRNA Vaccines Through Dialogue. This is the second presentation in our new webinar series in collaboration with the Bridge Research Consortium, so we're excited to have you with us for this important discussion. I'm Antonella Pucci, the Manager of Immunization Initiatives at the Canadian Public Health Association, which is Canada's independent national voice for public health. And I'm responsible for managing Immunize Canada, a national coalition housed within CPHA, dedicated to promoting the benefits of immunization in the country. I'll be the moderator for today's webinar, and on behalf of CPHA, through Immunize Canada, it is my pleasure to welcome you to and to host this webinar. So for this webinar, we would like to respectfully acknowledge that our CPHA and BRC team members work and live across Canada on the traditional and unceded territories of the First Nation, Métis, and Inuit peoples. I myself am based on the traditional and unceded territory of the Algonquin Anishinaabe, otherwise known as Ottawa, Ontario, and our presenter, Dr. Katrina Plamondon, is based on the traditional and unceded territories of the Syilx people in interior British Columbia. So on to housekeeping. This webinar is being recorded on Zoom. A recording of this webinar will be made available on immunize.ca and Immunize Canada's YouTube channel shortly after. If you have any questions regarding technical difficulties, please contact immunize@cpha.ca and we'll reply to you as soon as you can. And if multiple people are experiencing the same problem, we'll address it live via a broadcast message in the chat. As for presenters and, as for questions and answers, answer session, you're welcome to submit or upvote your questions for the speaker in the Q&A tab at any point during this webinar, and they will be answered at the end of this presentation. However, due to time limitations, not all questions can be answered. Finally, we would love to hear your feedback, so please fill out our short 5-minute evaluation survey upon exiting the Zoom platform. We'll also be sending it via email as well. So before we jump into today's webinar, we'd like to remind you a little bit about the Bridge Research Consortium and how their partnership with us at CPHA came to fruition. So the Bridge Research Consortium, or BRC for short, is a project within Canada's Immunoengineering and Biomanufacturing Hub, led by the University of British Columbia, and it is one of the 19 projects funded by the federal government through the Canada Biomedical Research Fund to support Canada's life sciences strategies aimed at rebuilding a strong and resilient domestic biomanufacturing and life sciences sector ahead of a future pandemic. You see, Canada's work developing new vaccines and immunotherapies holds real promise, with the potential to create innovative vaccines and therapeutics that could save lives and improve health. But one key challenge remains, which is achieving public trust and optimal uptake of these advancements. And the COVID-19 pandemic highlighted that scientific innovations alone aren't enough. Success depends on whether people can and want to use these innovations. Hence, building public trust and equitable access is just as critical as advancing the science behind developing new vaccines and immunotherapies. Therefore, integrating the social sciences and humanities into the therapeutic pipeline and immunization system can contribute to addressing this challenge. And that's exactly where the Bridge Research Consortium fits in. This multidisciplinary team of leading social scientists and humanities scholars, along with public health and biomedical experts from across Canada and beyond, help bring together, or rather bridge, wide-ranging expertise and perspectives to better understand and support public trust and equitable access to new vaccines and immune-based innovations that strengthen Canada's readiness for future public health emergencies. And through the interdisciplinary research, training, and knowledge mobilization activities, the BRC's approach focuses on proactively understanding evolving challenges like mis and disinformation, meaningfully engaging with diverse knowledge users and priority populations, and finally creating innovative trust-building initiatives. So the Canadian Public Health Association, through Immunize Canada, We'll partner with the BRC to share opportunities for the public health community to inform ongoing research, co-create knowledge mobilization outputs that support the implementation of evidence-based practices, launch this quarterly webinar series to explore emerging topics like today, and participate in other activities, which include but are not limited to hosting future workshops and training sessions and developing a guide for healthcare workers aimed at demystifying the different stages of the therapeutic pipeline. So today's webinar will feature work underway through the BRC's Dialogue Platform, drawing lessons from the mRNA COVID-19 vaccine experience to explore what it will take to build and sustain public trust in therapeutic innovations that play a pivotal role in limiting the scale and impact of harm from emerging pathogens. Dr. Plamondon will share highlights from the current dialogue series and reflect on how this responsive, collaborative approach to learning can itself help strengthen trust. So with that, I'm delighted to introduce our speaker, Dr. Katrina Plamondon. Dr. Katrina Plamondon is a woman of Cree, Irish, Jewish, German, and Quebecois ancestry who lives on the traditional and unceded territory of the Syilx people in the southern interior of British Columbia. She is an associate professor in the School of Nursing within the Faculty of Health and Social Development at the University of British Columbia, Okanagan campus, and a co-director of the Equity Science Lab, where she leads interdisciplinary research and training to advance equity-informed action for health. A registered nurse with experience in acute care, public health, and health system leadership, Dr. Plamondon equips system leaders, researchers, and health professionals with a practical tool to integrate equity into everyday decision-making. Her work contributes theoretical and methodological insight that shapes policy and practice in public and global health. Through creative consensus building and a dialogue-driven approach, she brings diverse stakeholders together to develop meaningful collective solutions and plays a national leadership role in global health. So now I would like to hand over the mic to Dr. Plamondon to share her presentation.
Thanks, Antonella. And thank you for that warm introduction. And it's really lovely to be with a large group of folks. I can't see all of your faces, but I'm sure there are many of you that I know. And for those that I don't know, I'm happy to connect with you today. So I'm really happy to share with you today a little bit about our dialogue research that's currently going on around public sentiments and mRNA vaccines, specifically around what to do with sentiments of hesitancy in the context of being ready for the next pandemic. So I'm going to start with just a few acknowledgements of our amazing team. I have a wonderful team of folks that works in the Equity Science Lab with me, Anjali, Jenna, Rodrigo, and Amy. I know Amy's here today. The rest of the team may not be, but really wonderful group of folks to be working with, alongside the support of several folks from the BRC Secretariat and leadership team, and just a few acknowledgements of funding there. So this is my plan for today. I'm going to start with a little bit of background. I actually will give just a very brief introduction to what deliberative dialogue is, and then we'll talk a bit about why this dialogue now, what the purpose of our dialogue is, and what we're hoping to achieve. I'll spend a little bit of time sharing some of the highlights of the knowledge synthesis work that went into informing and getting ready for this dialogue series, and then talk about who and how we're engaging folks across Canada in these dialogues, what we're hearing, and then I'll open it for some next steps and reflections and invite your contributions. So first, what is deliberative dialogue? This is a methodology that I really love because it brings diverse perspectives together in a future-facing and solution-seeking space. It really draws on hope and appreciative kinds of perspectives. It relies on our collective creativity, allows us and invites us to think about what kinds of futures do we want to build together? It's very aligned with equity practices in science, especially if and when we pay attention to including people in ways that actually allow them to share their perspectives and insights. It's kind of similar to walking into or joining a virtual workshop. It's quite conversational in style, but it's quite very purposefully structured and facilitated. The goal is to explore the implications of what we know about a problem, in particular, what empirical evidence is available to us in context. And that context includes the breadth of knowledge and knowledge systems that are brought to the table of dialogue by the folks who are participating. Because we are asking people to join us and think about and share their insights about big societal problems, it's important that we use deliberative dialogue around issues that are quite pressing and that actually do affect the people who are coming into the conversation. So it's not just exploratory, it's intended to really be applied. In the deliberative space, it's a really generally positive experience. People get to hear from others and engage in conversations that they often don't have built into our day-to-day work. And they can really build a sense of connection and trust amongst people who are participating in the dialogue. It also allows people in the dialogue to hear from and understand the experiences and perspectives and realities of people that are somehow connected to the same problem, but for whom we don't have a lot of routine interaction. So it helps us to overcome some of the systemic fragmentation that makes it difficult for us to understand or know what's happening in other parts of a system. Sometimes even within our own local systems, it's hard to know what other people are doing around the same problem. So it can really help us to identify opportunities for synergy where we can do more collectively than we might be able to do apart, and for harmony where we can align our efforts so that we are all moving in a good way towards a shared direction. I should add, actually, briefly, I didn't say this. It's different from focus groups. So sometimes people will ask me, why is this different from a focus group? The difference is that the facilitators often also have some kind of connection to the topic of dialogue, and the experience within the dialogue is relational. So it's not one directional, it's not extractive, it's not a researcher asking a question of a group of people and then taking their answers away. It's actually that we are working together to create interpretations, to make sense of, and to create directions together. And so the research process, the data handling practices, those sorts of things look different than it would look like if we were doing a focus group. All right. So why this dialogue? Why now? I suspect that many of you will not be surprised by or had reasons to come to this dialogue that connected to why we think it's important right now. Over the course of the pandemic, we saw quite a lot of shifts and changes in public sentiments around vaccines. And I'll share a little bit about what we're hearing from folks about what they think of that in a moment. But really, we have this tremendously disruptive experience of making it through a pandemic. And we also encountered an increasing amount of tensions and many factors that were happening alongside the pandemic amplified some of those tensions. And mRNA vaccines kind of got caught up in the middle of all of this. And while they represent this tremendous advancement in the therapeutics that we can use to help us navigate and reduce the harms or duration of a pandemic, they also have been met with kinds of hesitancy and distrust and narratives that have affected and posed challenges to public health that are new to navigate. And so while there's all this opportunity, there are many unanswered questions. And at the same time, we know that it is very likely that we will face another pandemic not just in the far future, but in the much more near future. And so why this dialogue now? It's really to contribute to our collective thinking and efforts to be ready for the next pandemic and to not be caught in a scrambly kind of moment of catching up with or trying to find solutions to really big problems in the moment that we must find them, and to be able to navigate some of these complexities in a forward-thinking way. So to get ready for this series of dialogues, we really wanted to spend some time looking at the existing evidence that's available, which is common to deliberative dialogue. Usually we do some kind of a knowledge synthesis and we present a summary of that synthesis to people who are coming into the dialogue. So we give them a brief in advance and we give them some questions for reflection. So the questions that we're guiding our efforts to both generate new data and look at existing data were really around how public perceptions, attitudes, and behaviors evolved around mRNA technology, and what we think are the most promising ways forward as we look towards pandemic readiness, and who needs to be involved, what sectors need to be involved, what kinds of things are affecting public sentiments, how do we navigate those? How does it affect the way that we communicate or collaborate as people working within public health systems? We did interviews. We worked a lot with BRC folks, our team. We did a rapid review, scoping review, and environmental scan. And then the deliberative dialogue phase is really leveraging and tapping into a wide range of knowledges from different kinds of knowledge that people bring into dialogue, like our cultural knowledge, our experiential or organizational knowledge, our disciplinary knowledge, knowledge of context, of the geopolitical climate, all of these things, to ask really what knowledge gaps and practice gaps exist, who is affected, what does it affect, how does it affect them, and how can we respond? What can and should we do? I'm going to skip over this. If anyone wants more, we did a scoping review and had some really interesting initial findings. Perhaps I'll just highlight here that in our scoping review around vaccine hesitancy and mRNA vaccines particular, confidence and uptake, one of the key findings was that hesitancy is not necessarily the presence, doesn't necessarily mean that it's because of misinformation. And it doesn't necessarily mean that there is not sufficient or not, that the information is not present. It's that maybe the information doesn't address the questions that people had. We also saw a lot of concern in that scoping review about safety and the long-term impacts of COVID vaccines, and that not the people who are being asked these questions were not always equipped with resources to be able to respond to the questions that people were bringing forward. So direct care providers, general practitioners, nurses didn't always have resources immediately available to be able to answer people's questions. This is just an overview of some of the background, just expanding on that scoping review. So we highlighted in our pre-dialogue work some central tensions, recognizing pandemics pose critical threats, that public engagement and trust are among the important dynamic factors that influence how viruses emerge, how they move through and affect populations, and therefore are really important considerations for us in thinking about pandemic readiness. We also recognize that therapeutic innovations like mRNA were among the most rapidly adaptive tools available to protect health and prevent illness from emergent viruses. But these tools are met with a variable level of acceptability and often confronted with polarized narratives, hesitancy, doubt, skepticism, and a lot of noise lately. I'm going to skip these, or I'm just going to keep moving. So who are we engaging and how? Recognizing all of that context, we designed a deliberative dialogue study that engages a wide range of folks who are involved or connected to in some way to mRNA vaccines. And so this includes people who are in positions of power, authority, or decision-making, like government officials, people in decision-making roles in professional bodies, people who are situated within health systems, so regionally, provincially, or nationally, and are making decisions about or communicating about vaccines, people who are in health systems leadership or professional practice leadership roles, people who are in science roles or knowledge mobilizing roles across the entire spectrum, from discovery research up to and including research on delivery and perceptions about mRNA vaccines, on designing and immunization strategies and programs, on surveillance, population public health, people involved in ethics or communications. We also include people who are involved in the media, so journalists, people who are social media influencers, and also people who are affected. So in particular, licensed healthcare providers that have roles that require them to be engaged in communicating or responding to questions about vaccines, especially in supporting people who are experiencing hesitancy. And people who are members of the public who have especially heightened challenges related to trust or conditions that preclude their representation in clinical trials. So pregnant people, people who are making decisions on behalf of others, like parents, people who are immunocompromised, for example. So all of those folks are people who we are inviting into dialogue. We have this series where we engage with people, we synthesize what we hear, we listen for direction, and then we bring that to the next conversation. And so we've had about 5 dialogues so far. We anticipate having several more. We also have the opportunity for people to participate in a self-led dialogue. So we have a toolkit that people can use if they're interested in holding a dialogue within their own group. And for each of these, the people who are invited into conversation, they receive a bit of material before the dialogue, and then we guide them through a set of questions during the dialogue, and then we follow up with them after. So each round of these dialogues gets its own report. We've started the dialogues with power holders, systems leaders, and advisors, and also these are sort of merging a little bit with scientists and knowledge mobilizers. And in the next round, we're extending the dialogues to include people affected, in particular. Youth have been a group that we want to engage a little bit more. More with journalists and social media influencers and direct care providers. So this is an example of the kind of brief that people get in advance of the dialogue. We share this about a week in advance, and it just gives a bit of a highlight of grounding for the dialogue, so people can have a chance to sort of wrap their heads around, here's a little bit of information about the context, about what we mean by particular terms, what the goal of dialogue is, and it offers some questions for reflection, so people can think about these before entering into that dialogue space. Just because that text was extraordinarily tiny, I'm just offering these questions for reflection. These are from our last series. We adapt these as we move in different cycles, just so that as we're hearing more questions come from dialogue, we're able to provide a responsive kind of approach to the questions that we're providing. So that's all where we have the who and how of what we're doing with these dialogues. And now I'm sharing with you a bit of what we are hearing so far. So we've had really rich conversations. I think that some of the things that stand out really prominently have to do with considerations of time and the dynamic nature of public sentiments. that those sentiments evolve over time and really shifted as we moved from one point in the early in the pandemic when we did not have vaccines yet, and there was a lot of excitement and anticipation and concern about having vaccines as soon as possible. And those shifted later to narratives that expressed concerns about the scientific process, or perceptions that things had gone too quickly, or that steps had been skipped for us to get to having vaccines as quickly as we did. And so there's an interesting dynamic shift in what people were, what narratives were circulating, and where those were circulating. We heard a lot and continue to hear that mRNA vaccine sentiments, and any vaccine sentiments for that matter, they're not just a health issue or a public health issue, they're a socio-political issue. And the nature of this socio-political issue has elements that are both mRNA specific and some that are actually not specific at all to mRNA vaccines, or maybe not even specific to health. And so, for example, the mRNA specific sentiments that have socio-political dynamics have highlighted that there is a really wide range of scientific and digital literacy, that it's inconsistent, and that public health communications didn't always meet people where they were at with their levels of literacy. And it's a tricky balance between not engaging in a condescension, but also not assuming that people know more than they know more than they do. And adding to this was a lot of confusion and overload. There was so much data and information, and sometimes conflicting messages, even sometimes messages that emerged from people who are in positions of influence, even within public health, that undermined trust in mRNA vaccines in particular. And that confusion is now being reinforced years later by other people in positions of influence who are participating in actively undermining trust in mRNA vaccines. Also specific to mRNA vaccines were concerns about the lack of transparency and the public-private partnerships. People have questions about this, legitimate questions, and there wasn't a lot of transparency to answer those questions. Even when those questions were posed, sometimes the answers were met with vagueness, and that this continually vague or lack of transparency around those partnerships, or the impact or the relationships between public investments in developing vaccines that then make profits, who gets vaccines, where do they go, etc. These things fueled distrust and doubt in the motivations of people involved in developing or distributing vaccines. But overall, we also heard that the rhetoric or narratives that circulates around vaccines are often being fueled by or spurred by people or forces that, sociopolitical forces, that have actually motivations that have nothing to do with health, but rather are really, their goal is to spread chaos, and to use different things where there is a seed of doubt or hesitancy or distrust, to concentrate power, or for monetary reasons, that there are, and that we cannot underestimate the role of these influential voices that are acting in direct conflict with public health goals, and actually in conflict with health goals, even if they say that their interests are about health. So we can't underestimate the maliciousness or the purpose of those voices. As those voices have gotten louder, things like choosing to vaccinate or not vaccinate, or someone's vaccine status, became a source of identity, resilience, strength, including being really particularly aligned with different kinds of coded language. In particular, we are hearing, and the evidence shows this too, that those are really aligned with different political ideologies and can be kind of broadly grouped in right-leaning or left-leaning, and that coded language serves particular interests, especially does a good job at keeping us separated and divided. These issues and forces affecting these vaccine sentiments also evolved at a time when, over the course of the pandemic, a lot of coercive policies were in place, and that we've heard from dialogue contributors that the level of coercive policies, or they wish that if we look forward, their recommendation is to do less in terms of coercive policies, because these erode trust and contribute to fatigue. And so we really have to think about prioritizing think about the long-term overall goals and balancing different public health measures in limiting coercion. What else do I want to highlight here? We also have been hearing quite a lot that not all hesitancy is the same. So there's sometimes anti-vax sentiments and hesitancy sentiments are conflated, and we've heard from people that they absolutely should not be, and that there are really important and distinct contexts and historical reasons that certain groups are hesitant or might experience hesitancy and distrust. And we need to be attentive and respectful of those reasons. In particular, for example, for Indigenous people, Black or newcomer non-English speaking communities, for whom the messaging and communication strategies didn't necessarily acknowledge those contexts or really connect with communities and partner with trusted leaders to address those kinds of concerns. I'm going to move to the timelines. We're really also hearing in these dialogues that the sentiments shifted over time, and we really had different phases of moods or sentiments that were affecting how people talked about, what they talked about, and what decisions they made about vaccines. So in the earliest phases of the pandemic, there was a sentiment of uncertainty. There was a lot of solidarity and hope, excitement about the possibility of vaccines. And also this was a time of lockdowns. And it was a time when we had actually quite a lot of social upheaval. There was in May of 2020, George Floyd was murdered. And then the same month, the Kamloops band announced the discovery of 215 unmarked graves from residential schools. We also had intense disruptions to social life. And so by May of 2021, shortly after mRNA vaccines were approved, people were very motivated to be vaccinated. There was a high demand for vaccines because people had a high desire, a big desire to reintegrate in their social lives, to be able to do things that they had been restricted from doing before. So in that bottom arrow, you can see in December 2020, mRNA vaccines were approved. Moderna and Pfizer-BioNTech were approved. By 2021, these vaccines were, December 2021, they were approved for children. Also at that time, new variants were emerging. We had a continuous need to adapt the vaccines to new variants of the virus that were emerging. And so we also had the waves of booster programs. As we moved into those waves, in between around December 2021 and the summer of 2022-ish, the mood shifted to more tolerant. So the appetite for vaccines remained high, but this tolerance was mostly because people wanted to be able to get back to life. They wanted the pandemic to stop disrupting daily life. They wanted to move on. And so that tolerance remained, participation in booster programs remained relatively high So we moved from tolerant into fatigued. People became impatient with restrictions, a bit fatigued by and confused by how many boosters they needed. And the demand for vaccines started to drop. We also continued to have a lot of social movements that were going on, and we had a change in leadership in the United States that also led to a massive divestment in mRNA research and development. And so this continued to affect vaccine sentiments, and people started becoming distracted by competing polycrises happening around the world, and this continues today. Alongside this timeline, we had disruption to childhood vaccine programs. We had growing hesitancy and distrust of other vaccines broadly. And quite shockingly, Canada lost our measles eradication status in November of 2025. Still, by December 2025, billions of doses of mRNA vaccines have been delivered. COVID remains in the top 10 leading causes of death in Canada. While our vaccination participation in targeted populations is high, our overall vaccination coverage right now of the total population is only 3.9%. And as we look to the more recent past from over 2025 until today, we've seen a lot of other things happening that are affecting vaccine sentiments, including trusted sources. So officials in Alberta, in the United States, at the CDC, for example, releasing reports that undermine and claim that mRNA vaccines are unsafe, which is in direct contradiction to the evidence that we have available. We also saw shifts in vaccine availability with, for example, in September 2025, Alberta announcing $100 fees for COVID vaccines. And continued confusion, including as recently as this month, the US FDA first refused the Moderna application for a new mRNA flu vaccine and then agreed to review it 8 days later. So over the last 18 months or so, the mood and narrative and sentiment has gone from distracted to overwhelmed. And perhaps now in a more apathetic and confused state with a huge infodemic of an overwhelming volume of conflicting messaging. So I'm going to spend 3 minutes on this, and then I will close it off and open it for some conversation. So what are we hearing from people about recommendations? What do people want to see, and how can we build healthy trust where people's trust is both informed in making good decisions that is grounded in evidence, and also where the trust in public health, in government, in the science is also healthy. And here's what people have said so far. There's sort of 4 broad areas that people talk about when they start making recommendations about building healthy trust. The first being that we really need to invest in understanding. And understanding extends to understanding each other better, understanding our social landscapes better, understanding who does what, and what goals actually span across settings and across social communities or publics of people with loosely connected interests. We need to understand with more nuance. We need to understand the impacts of our language and what is coded immediately as being affiliated with one or another political ideology, and to try to find language that falls outside of that coded range. We need to understand our own assumptions about the communities that we're working with, and unpack those assumptions, really examine what the literacy needs are as it relates to digital literacy, health literacy, and science literacy. We need to understand with nuance the motivations of different influencers who are affecting the public narratives about vaccines or about mRNA, and to know that those motivations might not always be with beneficence in mind. They might not always be about health or collective health. Those motivations might be actually self-serving. We need to understand people's reasons for behavior, recognizing that behavior does not always immediately follow hesitancy. And we need to situate all of this within a broader socio-political climate. When we communicate, we need to think about communicating with very tailored strategies that meet people where they are at, so that meet people's language needs, recognizing we have an incredibly diverse diaspora across this country. And so English or French are probably not going to be the languages that all communities need. And so we have to think about connecting to people in ways that actually resonate with them, that are culturally accessible, and that we do this with humility, with a sense of being curious and a willingness to learn rather than assuming that we know. To really meet data with storied and show the impacts of vaccine or not having vaccines available. So for example, with measles, if people took for granted that they didn't see the impacts or consequences because we had high herd immunity and we were able to not have measles. We didn't have cases of measles, but without really appreciating the impacts, it's difficult to know, or that affects people's sentiments about how important a vaccine is. There are a lot of recommendations around how we can equip ourselves to be able to navigate future pandemics, with a lot of attention to ensuring that care providers and trusted leaders within communities, so finding influential leaders, trusted people in faith communities, our cultural communities, are also equipped with tools and resources to be able to answer people's questions and have meaningful conversations about their concerns. That we need to balance our public health workforce with a communications workforce that understands social media and media in general, and pays attention to, monitors what narratives are circulating and are equipped and able to respond to those. And that we need to engage. And I find this really exciting. A lot of recommendations are really about starting to build trust with each other in our local communities first, investing in third spaces and finding opportunities to rebuild trust, connection, belonging within our own networks, to really promote a sense of shared responsibility and to invite participation in public science, that actually all of us are affected by vaccines and the therapeutics available to us, and that we can all play a role in generating and participating in science. So there's some very particular and exciting recommendations around that. So I've talked longer than I anticipated. I'm going to just leave this up for a minute and then I will open it for questions. We would love to hear from you. We have dialogues ongoing. We will be at the conference in Montreal coming up very soon. We have toolkits available. If you'd like to hold your own dialogue with your own network of folks, you can integrate it into a standing meeting that you might have and spend 45 minutes or so talking about these questions and working with the dialogue brief that we have. Or if you're interested, you can let us know, and we might have a dialogue that is coming up that and fits with your schedule. So I will stop there and ask you if you have recommendations about who we should engage, what you would love to see coming from these dialogues, and if there's other questions that we should be asking that I haven't highlighted yet today.
All right. Thank you so much, Katrina, for these important insights and for sharing your work that you've been doing, incredible work you've been doing on deliberative dialogues. So now I would like to remind everyone that questions will be taken in the Q&A tab. You can like other people's questions to prioritize them. And we'll do our best to answer as many questions as possible, but please note that we may not be able to address them all. So I think starting off, we did get some webinar questions. And one question actually really spoke to your discussion around literacy in particular, and the emphasis on literacy at the end. So do you have any ideas for sharing resources or examples to the public about mRNA vaccines, especially when it comes to maybe speaking with patients who are hesitant and maybe don't have the tools to navigate with all the misinformation that's out there?
Yeah. I think the one thing I can say with some confidence that we've heard and we see in the literature is that people are not hesitant because they don't have enough information or because they it's not just because they have a particular political stance. It's actually that their goals, they carry the weight of wanting to protect, for example, their children and do the very best thing for their children. And they're hearing competing things. They're being told, just trust us, just trust the science. While that science within the scientific community, there isn't a consistent message. And where sometimes within the scientific community, we don't have immediate answers. So when someone says, well, weren't they rushed? And how could they possibly have gotten these vaccines so quickly? If those questions are met with dismissiveness or minimizing those questions, or without a confident answer about how the scientific process works or just how rigorous our safety reviews are in Canada, if we don't have that immediately available to us, and I can say this as a nurse, I don't know that our nursing, my undergraduate education, I don't know that I would have been able to answer that question in the same way that I could now, having learned a lot more about the research process and what goes into approving a vaccine or medication for distribution. And so these are questions that we need to be able to hold with respect and kindness and care, and to give people time to really recognize that their questions are coming from a place of really wanting to do the best thing that they can for themselves or their family. And Christina is just highlighting that we do have this is a key goal of the BRC overall. So we will have resources available, and especially being able to equip frontline folks with something that goes a little bit more beyond the I'm not coming up with the word, but you get that little information sheet to hand out, the handouts on our vaccines. That's not answering people's questions enough. So going through that handout isn't quite enough. And public health nurses, general practitioners, they need more than that. And so we will be developing tools that are grounded in evidence and help to respond to some of these questions that we're hearing again and again.
Yeah, thank you so much, Katrina. I think like with the overabundance of misinformation and information, it's impossible to just say vaccines are safe and effective. And actually, I kind of want to lead to this one question that we got from a participant saying, so any comments from participants on accountability for overselling the vaccines? I know there are a miraculous innovation and fantastic at reducing acute mortality and severe illness and are safe. However, they are also sold as being effective at stopping transmission. But breakthrough infections are common, and this is proved not to be the case. Do you think acknowledging and correcting that sort of thing would go a long way towards restoring trust, I guess, around the additional parts of the vaccine?
It's a really good question. So it sort of touches on like, what are people's expectations of a vaccine? And also, what did we say this vaccine could do? Like what did we set people up for in terms of expectations? And I think it's a really fair point. So some things that undermine trust were people got vaccinated and then they still got COVID, or they got vaccinated and they felt terrible for 2 days, 3 days, and had to take time off work. It's a hard sell when getting vaccinated is hard on you and has implications for your life, sometimes that people don't have the privilege to be able to absorb, and then they still get COVID. And I think that, yes, I think we can do more to both be very humble when we're communicating about what we know about this vaccine and what we don't yet know. And to really emphasize that science is iterative and it's responsive, and actually it is almost never absolute. And so once we think something is safe and effective, we are still going to learn as we go along. And the notion that a vaccine should absolutely prevent us from the virus entering our body, for example, is probably not a helpful thing to it's not a helpful message. And so if we need to be able to talk about what does this vaccine actually do, and what are the benefits of it, both for me, for people I care about and love in my life, for people I might interact with in our, like, who might be immunocompromised, or who might getting vaccinated is not just for us. And so that cell needs to come as kind of a package deal with some humility. I think we've had some really great and exciting suggestions from people who are in this discovery and biological sciences, who talk about actually what the science is trying to, what it allows us to do, where it is limited, what we are still learning. And there might be vaccines or innovations in the future that do prevent something from entering our virus, or completely prevent transmission, but we shouldn't oversell it when that's not the reality. We need to be honest about that, but meet it with honest reasons for why it's still important or good for particular groups to be vaccinated.
Yeah, absolutely. I think the overselling of vaccines, and maybe not, like, for example, the government being upfront about evidence being updated, because there was often, it would always say there's new recommendations, but really it's the reality that science is always evolving. And I think we need to be a little bit more honest about that science is always evolving, because it does erode trust when, we're not very upfront about that. It's just kind of like, oh, here's something new. So I think that's a really important point.
Yeah. Yeah. And
Yeah.
instead of getting worried about being, like, saying something today that then we have bad publicity because we're proven wrong later, rather the message should be, here are the limitations of what we know, and here's what we're continuing to monitor, and some celebration about our scientific systems that allow us to be responsive. Like that's a strength. It's actually a good thing that we learn from evolving and emerging evidence. But it's often presented, there's like a risk aversion of we have to be right, and we have to be fully right, and we don't want the risk of bad publicity gets in the background of some of that communication. But I think that it undermines our own goals.
Oh, absolutely. So moving on to another question from a participant. It's related to Indigenous communities. So what was the level of basic trust when engaged with Indigenous communities, if they were included? I believe this is in response to the deliberative dialogues.
Yeah, so it's a really good question. So 2 points. One is, in our scoping review, we actually see very little attention to Indigenous communities or Indigenous people. There's not a lot available, but we are doing a sub-analysis right now on what is available. So we will have a bit more nuanced from the research that was done around vaccine sentiments leading up to it. Also, we're really appreciative there are very good reasons why Indigenous communities are skeptical. There has been a history of experimentation so when Indigenous communities were first prioritized for access to vaccines, that was not met with as a universally good thing. So some sentiments were, well, why us first? Are they going to try it out on us and see how it goes, and then let other people try it, rather than seeing it as this is a priority group because of a wide range of inequities that are currently existing and things that make susceptibility and vulnerability to harms from COVID makes them a priority population. So that was not communicated with as much care and respect and humility as it needed to be. And the process of building trust is not, it can't be like fast tracked. It's not something you can sort of leapfrog to just assume or demand trust. It needs to be built. So one of the things in the deliberative dialogues that we are doing is creating tables for Indigenous folks to contribute to. So I'm really hopeful that we are going to be able to bring together an Indigenous youth table of dialogue that will be specific to their perspectives and insights. Because of their roles in their communities, I think they're really a brilliant and important group to engage with. So that is coming soon. And if there are groups that want to use the self-led toolkit or engage, we're happy to hear from more and to continue to explore that.
That's wonderful. Thanks so much, Katrina. So we are at the hour. We do have one more question. If you don't mind taking one more question, it's just related to long COVID, actually. So how do you engage anyone outside of the people affected category? I'm in the long COVID space, and there seems to be no appetite for public health, political leaders, etc. People in positions of power seem to have no interest in long COVID, possibly because raising awareness would require action on their part and liability. I wonder if you have any thoughts on that. I guess before we end off, I know that's a big that's a big question.
Yeah, it's a big question, but actually, I would be really keen and interested in connecting with if there was some sort of a network or group or a point person where we could also hold a table of dialogue specifically for people who have experienced long COVID. We've also thought about creating space, and we're trying to identify folks right now who have had vaccine injury or who were vaccine hesitant or opposed and changed their mind. So those are all groups that we are actively trying to reach out to right now. So yes, please let us know if you have leads or would recommend anybody for that. I'm happy to, we will follow up on those. And there's a link that Elodie just put in that you can connect with to express interest in participating in the deliberative dialogue. You can find us if you're going to be at the conference. Tap my shoulder. We can have a quick chat. And yeah, we don't know entirely what the end outcome will be from these dialogues just yet. But so far, the rough edges are something like a framework to help us guide our efforts for building healthy trust. And it will build on some of those early themes that I shared before. But there's still lots of room to provide direction. And we want to hear from you.
Fantastic. Thank you so much again, Katrina, for this fantastic presentation. And I just want to note that we will be sharing the links that were shared in the chat. Thank you for all the informative information that's been shared by the BRC team. We'll be sending that once the webinar recording is available, which we hope will be available in, a couple of days. So with that, I'd like to end today's webinar by thanking, that's new. By saying thank you to the participants and, of course, again, to Katrina for presenting on this really important topic. Please feel free to take the post-evaluation survey upon exiting the Zoom webinar. And with that, have a great rest of your day. Thank you, everybody.